Okay. All right, so I'm gonna make sure I'm on the right mic here. Okay. All right. So tonight we're going to talk about I don't know what happened to my title page. It's interesting. All right, we're going to be talking about respiratory emergencies. We're going to be using a combination of things. We're going to be using the sim man up here. We're going to be listening to our own lung sounds, breath sounds, heart rate, stuff like that, just so that you guys can start to get used to doing assessments on each other, as well as the sim man. Hopefully the sim man works. We're having a little bit of issue with him getting him set up, so if he works, that'll be great. We're going to identify adequate and inadequate breathing, be able to distinguish the difference between the two. We're going to identify and learn how to treat the patients with difficulty breathing. We're going to talk about the use of CPAP, prescribed inhalers, and prescribed small volume nebulizers. Does anybody know what a small volume nebulizer is? Okay. The little thing, we use them on the truck all the time, that use little things like this, put a small amount of medication, aerosols it, brings it up in here. We're going to talk about the use of the CPAP device, which we have one here. And we're going to talk about what kind of medications are most commonly used for breathing problems. And we're going to go over several different illnesses that contribute to this. We're also going to be going in and out of the book quite a bit, just to make this a little bit easier. We get to know what the book says about it, and then we'll discuss anything that needs to be discussed more than what the book says. Which reminds me, if I'm going to do that, I need a book. Here it is. All right. So an airway review, we talked about this a little bit. Greg talked about this a little bit the other day. Air comes in through the what part? What are these areas? Upper airway. Okay, upper airway. This is the nasopharynx. This is the oropharynx. And the back is the pharynx and the larynx, which connects to the trachea, which is the start of the lower airway. So the lower airway goes from the trachea down to the lungs. What we call the two branches, what? Bronchioles that split into bronchi. Oh no, you're right. Bronchi splits into bronchioles, which ends in alveoli. Right. And what's this little notch here called? Anybody know? For the lung split. So it doesn't seem like it's very important, right? It's a little split, right? It's called the carina. And it's been on just about every test I've ever taken for the National Registry. Now, National Registry has changed up their stuff a little bit, so might not be there. Just know that with two branches of the lung split off, it's called the carina. Okay. All right. So I took some time this week. I'll pass this around. Actually, I took some time, about an hour this morning. We talked about positive and negative pressure, right? So we got here a set of lungs. And as you breathe in, the diaphragm goes down, pulling air into the lungs, pushes out, inflates the lungs.
That's amazing.
Yeah, it's small too. you guys can pass that around, play with it a little bit. Cost $349 to make it. The most expensive thing we have here, other than the $35,000 sim man. All right. So when we're going through this, what happens when the diaphragm goes down? Pulls air into the lungs, right? When it relaxes, releases the air. Right. So we call this action what? Anybody remember?
Inspiration.
Inspiration and expiration, right? Which is the act of no, but close. Ventilation. This is where we get kind of screwed up. So where does respiration happen? We really didn't talk about this. As something that is in the pathophysiology portion of the airway. I don't know if did you guys go over it? Where the different respirations go on. Okay, so you talk about internal and external respiration. So internal respiration is where gases are exchanged within the lungs at the alveoli. Let me take that back. External respiration is where gases are exchanged in the lungs. Good air comes in, bad air goes out and is expelled into the atmosphere. Internal respirations are happening at the cellular level where gases are exchanged at the cellular level. So respiration is actually the passing of gases between two bodies. So whether it's cells internally or the lungs externally, still cells, but you get the point. So ventilation is what is the active action of us breathing. That's why we ventilate people with using a bag valve mask. Any questions on that? All right, so what are some characteristics of adequate and inadequate breathing? Yes, question. Question mark right there. Okay, equal chest rise and fall would be a characteristic of adequate breathing, right? How about inadequate? Cyanosis.
Noisy breathing, accessory breathing.
Okay. And where would we expect to see cyanosis first?
Lips.
In the lips, around the lips, right? Okay. You turn to page 5.2 in your book. There's table 19.1, 522. And it talks about different signs and symptoms that indicate adequate and inadequate. So for an adult, our respiration should be what? 12 to 20 breaths per minute. This should be what kind of rhythm? Regular, right? So we should be at a normal rate. So 12, 20 times a minute. Breath sounds should be present bilaterally. Should be able to hear them in the tops, the bottoms, along the back. There's a little thing on in your book. I believe it's on 20. We'll get to it here in a minute. It has the places to check for breathing. Little landmarks on page 532 shows like 4 on the front, 4 on the back, and then it actually shows spots underneath the armpit that you can listen to for breath sounds. Why do you think underneath the armpits might be a good place to listen to breath sounds? Yeah. How about the fact most people aren't as heavy on the sides? So most people we have pear shapes. So we're usually pretty thin on the sides underneath the armpits. Even for us bigger guys that carry a little bit extra weight, right here is usually a good spot that doesn't have a lot of fat or even muscle over the top of it to block your sound. All right, back on page 522, we got diminished and unequal absent sounds for sounds, irregular patterns for rhythms. You know, so there's a lot of things that we look for inadequate breathing. But if we're seeing everything that looks adequate, does that necessarily mean they're not having issues breathing? No. So just because they look like they're adequately breathing, make sure you're looking for all the underlying things that might be there. So breathing is controlled by chemoreceptors located throughout the body. They base your breathing on CO2 level and your O2 level and your pH balance of the blood and cerebral spinal fluid. When those get out of balance, then the body starts reacting to protect itself. If you have a low CO2 level and a high oxygen level, your body might actually slow your respirations down and start building up that CO2 level again. On the contrary, if you have a high CO2 level and your oxygen level's normal, your body might start speeding up that respiration process, or that ventilation process, start expelling some of that CO2. Make sense? The body's really good at trying to protect itself. So, okay, inadequate breathing is not sufficient to support life. We talked about that a little bit on 524. They have some signs there: fast respiratory rate, showing irregular respirations, inability to speak, silent chest, low oxygen saturation despite supplemental oxygen, agonal respirations, irregular rhythm, and irregular quality. So once you start seeing those changes, then you need to start worrying about your patient and how you're going to be starting to treat that patient. Okay, how do we care for inadequate breathing? What's the most common way we care for it? Oxygen. So first thing we do is we take care of the airway, make sure they have an open patent airway. We give them oxygen. Okay. I put little references in here, just kind of for you guys to be able to look at it, but there's all the stuff: assisted ventilations, making sure the airway is open, making sure they have enough oxygen is about the best way we're going to be treating. What devices we use is going to depend on what we're seeing and what's causing the inadequate breathing. Again, we were talking, I think, with Greg, that anything below is considered inadequate. Anything below 10 respirations per minute is considered inadequate breathing. So our normal breathing rate is what? Inadequate breathing is a respiration rate of what?
Below 10 or above 22.
Right. 22 or 24? 22? It's 24. 24, I believe.
I thought I said 22 last week.
Yeah.
What's your book say?
24 in the book? Okay. What page is that on? Because
I don't remember. I remember seeing it.
okay, it might be in one of the other chapters
Yeah, it was
too.
in one of the other chapters.
Okay, yeah, so anything below 10, anything above 24, considered inadequate. Ventilation rate for adults, this is for doing artificial ventilation, is 10 to 12 breaths per minute. And that's a rate of about 1 breath every 5 to 6 seconds. It's important that when you're doing this, you're actually counting to 5 to 6, whichever you're choosing to count to. The way I do it is I breathe, 2, 3, 4, 5, breathe, 2, 3, 4, 5, breathe. That gives me a rate of about 1 every 5 seconds. So that's the way I do it. You'll figure out a way of doing it yourself. So just kind of as we're practicing on good quality ventilations, you should be able to see the chest rise and fall on this mannequin. So, and we have a couple other mannequins we can do that with too. For a child, it's 10 to or 12 to 20 breaths a minute, 1 breath every 3 to 5 seconds. Okay. And that's about the only difference between those two. You'll notice that there's not really, if you look through your book, there's not a chapter on pediatrics really. I think there is one, but it just goes over the bare minimum. All your pediatric stuff is in your chapters on the diseases we're talking about. So if you look through this book and you're looking through, there's a couple of sections in there that say pediatric notes. Very important you read through those and kind of see the differences on how we're treating the patients. Okay. All right. OPQRST sample. So how do we do an assessment on the patient? Okay, going through, yeah. All right. So you got a couple of things you need to do in here on ventilation and oxygenation. So one of them is oxygen administration. We're going to talk a little bit about that here in a minute. Is all oxygen administration? Okay.
2 copies of each.
Okay, so I'm just going to look at your, that was the wrong one. Medical. Okay, so we're going to talk about your medical assessment sheet. You guys don't have to pull it out. You don't have it. We'll just go through it. So anytime you go on a call, you're going to verbalize what? Is the scene safe? And we have our BSI. Okay. Determine the scene's situation is safe. Determine the mechanism of injury or illness in this case. Determines the number of patients, request ALS. Request additional resources, considers stabilization of the spine. So then we're going to go through and we're going to look at this patient. So our OPQRST sample history, our whole assessment starts the minute we walk in that door. What can we tell just by looking at that patient? If they're conscious or not. What else? Color. What position they're in. So if they're tripoding, can you hear breath sounds without a stethoscope? Yeah, if they're wheezing, audibly wheezing, you can hear that from across the room. So you can start picking up on signs and symptoms prior to even touching the patient. The minute you walk in that door. So you start your assessment at the beginning of the call, of course, but it really begins as far as the actual dealing with the patient. The minute you start walking in that room, you start hearing things. Okay. Look around you. Do they have a nebulizer sitting next to them? Are they on oxygen? Do they have a nasal cannula in? Do they have a non-rebreather? Do they have a trach or a stoma? They've got a trach airway in. Airway, we're going to assess it. We're going to determine whether it's adequate or inadequate. We're gonna initiate appropriate oxygen therapy. So if their sats are below what level, what percentage should we add oxygen? Hmm? A little bit higher? 94. So according to the book, 94 and below is inadequate oxygenation. Or is let me take that back. It's hypoxia. It's mild hypoxia, but still hypoxia. So if they're below 94 for test purposes and national registry purposes, we're going to put them on at least 1 or 2 liters per minute via nasal cannula if they're below 94. Now, what point should we be thinking about putting them on a non-rebreather?
Below 90.
Below 90. So once they hit that 90% below, we might want to start putting them on a little either non-rebreather or simple mask, try and get them back up. Definitely if they're in the 80s, non-rebreather. And what? We already talked about that. Oxygen administration. We just talked about that. Okay, so oxygen administration, non-rebreather, what should we start at? They're like 89, 88. Yeah, 10. So we can go at 10 liters to 15 liters per minute. Back when I did this, every patient got 15 liters per minute, non-rebreather. Didn't matter if they were sitting at 95%. They got 15 liters because we wanted them at 100%. Because we were talking about with Greg, over the years, they've determined that, yeah, oxygen can hurt you. It's going to kill you, probably not, but it can hurt you. And so we don't go shoot for that 100% anymore. All right, circulation, we're going to check for skin color, major bleeding, pulses, assists. There, yeah, okay. So that right there, just doing that gets you down to the history taking. So this is a medical call. We're talking about respiratory emergencies where you use QRST, right? As part of that. So what's the O stand for? Onset. What are we looking for there? Yeah, how long has it been going on? Did it come on suddenly? Did it come on gradually? That type of stuff. How about OP, provocation?
Is there anything that makes it worse?
Makes it worse or
Better.
makes it better, right? So if you come in there in tripod position, what are we wondering? Is that a better position for them? Is that a position? Right. So Greg talked about that a lot. It's getting them into the position of comfort. So that's what we're going to do is we're going to let them, as much as we can, be in a position of comfort. Quality. What are we looking for that? Okay. So sharp, dull, is it a squeezing pain, is it a radiating pain? Actually, I think radiation is next one, but that leads into that radiation. Okay. Severity. Now we want to know how bad it is. 1 to 10. Now, what do we normally use 1 to 10 scale for? Okay. Now you're talking to someone who's having difficulty breathing. They're not playing with them. How should you ask that question? On a scale of 1 to 10, 10 being you can't breathe, to 1 being you have no problem breathing. How difficult is it? It's still surprising because I used to do it too. Is I go in, how would you reach your pain? I'm not having any pain. Oh yeah, you're having breathing difficulties. How do I ask that question? It took me years to figure out that it's just real simple. Ask them, how hard is it for you to breathe? And then work it from there. So, time. Oh, Glad you guys remember where we were. Okay, so time.
How long's it been going on?
How long it's been going on, and I liked it the way the book said it. Maybe it says it on this page here. It's how long it's been going on. So if you can get an exact time as to when it started, it's great.
How long do you have this feeling?
Yeah, how long have you had the feeling going on? Yeah, you found it.
Normal stage.
Is that a read? Great.
Bonus.
All right, so
5 times.
yeah, how long you been filming this? What, couple of hours, couple of minutes prior? Has this been going on for a week? Is this a chronic problem that's been happening for years? It's amazing how many times we called to someone for an emergent call, and this has been going on for 10 years. So why did you call me today? What makes it worse today? Okay, and then start from there. All right, so sample history. So we're talking about, we talked earlier about what we see. So what do we call that?
Signs.
Signs. So when we walk in, we can start seeing things. We can start building up those signs. Sometimes you know the symptoms because you can hear them. You can tell what's going on. You can start using the signs to determine the symptoms. But it's still good to ask them what they're feeling, what they're experiencing to get their symptoms. So we can move on to allergies pretty quickly, can't we? So why do we want to know allergies?
It could be a allergic reaction.
Good, yeah, very much with breathing difficulties, that could be an allergic reaction. It could also be what happens seasonally. Hay fever, and that can trigger asthma. I heard it. So yeah, so it can trigger their asthma. Also, what were they doing right before it? So that was, I think we missed that on, no, it's still so medications. If we already know they have an inhaler, what's something we want to know?
When's the last time they took?
Right. And what else? Not only the last time they used it, but
When was the last week?
right? What's in it? What type it is? How many times they take it? So one of the common things we get called to every year at fair is someone thinking they have chest pain because of heart attack. Because they went to a fair and took 10 shots of their inhaler because they were having difficulty breathing. Now that heart is jacked way up, right? So how many times have they used it? So that's some questions you want to know. If you know they're on a nebulizer, we want to talk about, okay, so pharmacology is coming up. You're going to learn about 5 rights, right? 6 rights. So the 6 rights are right person for the medication. That medication is prescribed to them. The right dose of the medication. So if they took their inhaler and you look at their inhaler and for some reason they actually got smart and put the directions on the bottle itself and it says 1 to 3 squirt or sprays every 5 minutes and they've taken it 10 times. Have they taken the right dose? They overdosed on it. Yeah. So if they've only used it once, can they still use it more? Right. So right dose, right person, right dose, right medication, right date. Is it expired? Okay, some medications work just fine if they're expired. Some, they hit that expiration date and they're done. Some become more potent after they hit that expiration date. So you want to kind of know, is it expired or is it not expired? Right route. Okay. If this is an oral inhaler and they took it rectally, is it going to work? Probably not, right? Yeah. It's pretty extreme. Hopefully they didn't do that, but that's kind of the thing. You know, you'd be surprised what people will do. So, did they take it the right route? What's 6-1 color? Clarity, color. Yeah. So, is it clear? Is it the right color? So,
No.
Huh?
Clearly it's not on.
Okay, what is it?
Documentation.
Okay, documentation. That's for you. So, did you document it? Right? So, so those are the 6 things you want to look at for it. But clarity is coming up. So, okay. So we got medications. So we got the 5 R's. That's an introduction to it. You'll get it more when you get down to pharmacology, and it does talk about it a little bit in your book in this chapter when we get to medications. So, past pertinent history. So, what would be some past pertinent history for a respiratory emergency?
Asthma, allergies, or emphysema, COPD.
Okay. What else? They just go to the doctor the other day because they've had a cough.
That's the whole circulating problems.
Yeah, past illnesses. So these are things you want to look at, you want to be asking about. Do you need to know that they stubbed their toe and broke their pinky 10 years ago? Stubbed their toe, broke their pinky. Okay,
Stub toe, so hard you fall down.
true.
Pinky.
Man, I was looking ahead.
Or you could stub your toe so hard you get mad, touch the thing, and stub your toe off.
Yep.
That sounds like finger issues.
Okay. So last oral intake. Why do we want to know that?
Yes, thank you.
Yeah.
If I have something.
Okay, could be.
Or it could be a,
Okay, yeah.
be an allergic reaction.
Could be allergic reaction. So did they eat something that they ate chocolate chip cookie, but they're allergic to nuts, and this thing had pecans or, God forbid, walnuts in it?
Those made in the factory were nuts with them.
Yeah. That is like, it's really weird because nuts allergies are probably the most dangerous allergies out there. Those and latex allergies, because you don't have to be in contact with the item itself. You can be in contact with its dust. So, kind of wicked stuff. Okay, so events leading up to the present illness. Why do we want to know that?
So what could have possibly brought it on?
Right. So were they out mowing? And now their asthma's,
Were they
were they eating a cookie? Because, no, go ahead.
So you see signs of concern?
Did they fall? Were they having hyperventilating all of a sudden passed out? You might not have told you that to begin. Yeah. Yeah. All right. So that's pretty much primary assessment or history taking on this. That's as far as we're going to go on this sheet for right now. So we just covered down to secondary assessment. We're going to get a little bit into that later on when we get into the breast sounds, but we're going to do more hands-on stuff on that because I know you guys like the hands-on. All right. So pediatric assessment. What is the pediatric triangle? Did you guys go over that yet? In primary or secondary assessments? Good. So we're going to hit the pediatric triangle. It's not even covered in your book. So this is going to be extra information for you. But it goes into, at least it's not covered in this chapter. So pediatric triangle is appearance, work of breathing, circulation to skin. So when you come in, and we're talking about this, when we come into a room and we're looking at our patient, we're looking at their appearance, their work of breathing, and the color of their skin. we're doing this on every single patient we deal with. It's not just for the pediatrics. Pediatrics, you really see it. You know, you see that if they're having difficulty breathing, the retraction of their accessory muscles, they're really taking deep breaths, they're having nasal flaring, they're having a lot of issues that are standing out. You're looking at their appearance. Are they modeled? Are they in a tripod position? Does it look like they're having that physical issues? And then their skin color and the circulations of their skin is basically their skin color. Are they blue? Are they cyanotic? Are they flush? You know, what do they look like? What are some signs of pediatric respiratory distress? You look on 914 or 19.4, excuse me.
Their nostrils. Split colors.
Large nostrils.
Abdominal muscles.
Right. So you'll see a lot in children. You'll see what we call seesaw breathing. So as they breathe in, their stomach will go up and their chest will actually collapse. And then as they breathe out, their chest will come up and their stomach will collapse. And you'll see this seesaw pattern of breathing back and forth between the abdominal and the chest. And so that is a sign of inadequate breathing. They're working hard to breathe. So, all right. So here's kind of what the appearance or the pediatric triangle looks like. This is one version of it. There's a lot of them. If you go online, there's ones that go way more in depth than this. But if you guys want a copy of this, we'll make copies of it, give it to you. I couldn't find it in your book. That's why I went ahead and had to go online to find it. So I don't know if it's actually covered in this book. All right. We're going to talk about CPAP now. You're not seeing if it actually has oxygen in it.
No. Maybe there is because the one that has the.
No, there's some behind the desk there.
On the floor that do that.
All right, so there's a bunch of different CPAP machines out there. I'll have you guys kind of come up here and look at here. And
Is this terribly different from CPAP and CPAP?
no, actually, it's the same. Well,
Anything
little bit.
from my gland.
all right, so, all right, cool. I don't know how to turn this to just being on there. Oh, we'll do. Casey,
Right here.
why are you right there?
That's not my name.
Oh, Casey, I know which Casey this is now.
I don't know how you spell your name.
One more E, and then
Okay.
that would be me. But
All right, so Casey's out there in the real world, so we're gonna switch cameras real quick.
Shuffle
Hey, Casey, can you see the camera all right, or this one here? Not you.
I'm so confused.
Huh?
No, look on my face was just so confused.
Well, that case was here. And then we got two cases.
Yeah. So this is Casey Blaylock. He's doing it to get some. Okay.
It says yes.
Okay. All right. So we got Sim Man here. So what we're gonna do is figure out what's going on.
Here.
South Third, 702 South Third, 15-year-old female with stomach pain, tendencies.
All right, so we got Sim Man here who's having difficulty breathing. So these things do come with instructions on them. And on this one, if we look at it, we'll see that this is for an infant bag valve mask.
Well, helpful.
Okay, so the rate on this is, here is gonna be 8 to 10 liters per minute. Okay, so it hooks up, it looks similar to a what type of mask?
CPAP, sleep mask.
Well, see, it is a CPAP mask, but it looks real similar to a non-rebreather. Okay, the difference is it's got this little webbing on it. So the webbing is going to fit over the top of the person's head. And what I like doing is just getting the bottom of it loose. And you're going to want this to be fairly tight on the patient's face. The idea is to create a good seal around the patient's face. Don't recommend, this one's old and it's been used a lot, so do not be placing this over your face. So you're going to place it over the patient's face. Now, if they're having difficulty breathing, is this going to be, oh, yay. No. So, right now in this state, this is not a basic skill. In some states it is. It probably will be an EMT skill later on in life, along with a lot of other cool stuff. So what we're going to do is we're just going to slip this over the guy's head. And then once we get it over their head, while our partner creates a good seal, we're going to tighten it down. Now, we don't want to tighten it down necessarily until we have something going to it, right? So this should already be hooked up. And on these, you got a little dial here. Okay. Now, while your patient has a good seal, you're going to tighten this down on both sides, so to keep that nice good seal on. Okay, you shouldn't hear anything coming out from around here. Now his face is a little bit small, so you're actually blowing some into his eyes, but you want to keep it down to where it's fairly comfortable for the patient. It's got these little pads on here. You can set the volume on the side here. So we want about 15 feet. And what we're going to do is slowly adjust this out until they're having no more difficulty. It's helping them to breathe. So with this air continuously pouring in, I'm going to turn that down just so in here. So with this continuously putting air on there, what it's doing is forcing air down into the lungs, and it's keeping the alveoli open. So it's not allowing, and what happens with emphysema patients, COPD patients, is their surfactant in their lungs can actually be worn down to where as they breathe out, those alveoli collapse and they stick together and they no longer open up. And so what we're trying to do with CPAP is keep those open. So that's the purpose of the CPAP. Again, we have to show this to you, even though you can't use it here in this state, other states you might. So if you go to wherever to become a doctor and you're working as an EMT, this may be a skill you can do, or you may not be able to do glucose checks. So, any questions on that? You guys are going to get a chance to play. I want to get through the slides as quickly as we can, and then we can play with all this stuff. We're going to listen to the lung sounds on him here in a little bit. So, hand me, quicker go. That's right. All right, see where we're at. So indications for it, pulmonary edema, which is what? You don't know what pulmonary
Fluid in the lungs.
Yeah. So what's edema mean?
Swelling.
Swelling, right? So, and usually edema is relates to fluid. So when we talk about pedal edema, that's
swelling the foot.
right. So that's what we're talking about when we're talking about pulmonary edema. We got fluid or something in the lungs that's causing a difficulty to breathe. So what happens is when we're using COPD, CPAP, it's actually pushing that fluid out of the lungs into the interstitial space. We also use this in drowning victims and pneumonia victims to try and push that fluid out of the lungs. Does that make sense? Yeah. Asthma, COPD, and then respiratory failure. What we're trying to do now, and what really has been being shown in clinical trials and clinical studies, is that using COPD or CPAP on COPD, what we find is those people are getting intubated less. And for a COPD patient, getting intubated is a very risky proposition for them. Most COPDers that get intubated don't come off the tube. So if we can use CPAP or BiPAP to help them instead of intubating them, then that prolongs their existence on the surface. All right, so now we're going to get into some of the disease processes. So COPD, pulmonary chronic obstructive pulmonary disease, is basically a catch-all phrase. Okay, this entails with basically is emphysema, chronic bronchitis, and basically any other respiratory disease that presents like emphysema. Okay, so COPD is a collection of disease. Think about it, it's a lot like the AIDS back in the 80s. So the way it was used back then, HIV is actually the disease, AIDS is what it progresses into. Or, yeah. So when we're talking about it, if you look on page 539, it gives you kind of a rundown on it. I've got some highlighted stuff in my book for you. The one thing to remember is that Right. So one of the things to keep in mind on this is how we talked about it a little bit, is how the drive for respirations happens. The body gets used to having higher CO2 levels. And so as it has those higher CO2 levels, it gets used to being at that level. And the CO2 level now drives the respiratory system of this patient. It's not how much oxygen it has, it's now how much CO2 it has. And so when it gets down to, instead of, oh, let me take that back. So it gets used to that high level. Now it's no longer if the oxygen is too high, it's when it gets too low. So once that oxygen gets to a lower level, it kicks in to that hyperventilation, to that anxiety state for these COPD patients. So in order for them to do that, a lot of COPD patients, you'll see them living at 88, 89% oxygen. But once it drops to lower than, say, 80, or whatever they're not used to, like 85, 80, then it starts kicking in that respiratory need to drive or need to breathe type situation. And they have an issue with that because once you get down to like below 85, 80, you're not perfusing the brain really well. So these patients will start having altered mental status a lot earlier. And their drive, since it goes off how low the oxygen level is, can crash on you pretty quickly. So you want to make sure you're keeping up on it. Again, if you drive that CO2 level down too low, the body will actually begin to think that it's returning to a normal state and it'll stop breathing. So if you get that oxygen level too high, it says higher oxygen levels that result from oxygen administration may, in rare cases, signal COPD patient to reduce or even stop breathing, leading to respiratory arrest. So just gotta remember that. With a COPD patient, you really don't want them at that 99, 98, 100%. You want about between 90 and 94%. These are good patients to start out with a nasal cannula on, get them above 90, and then see how they do. Any questions on COPD? Again, with these patients, we're going to look at what they need to be treated. Do they just need a nasal cannula, or which they're probably already on one? Do they just need their oxygen bumped up to 2 or 3? You'll see these people with their oxygen, their nasal cannulas in their mouth, trying to get more oxygen. They'll have their oxygen cranked up to 6 or 8, and they're breathing it in through their mouth. Right. So pink puffers versus blue bloaters. I forgot to put a parenthesis at the end of there. So chronic bronchitis. Clinical diagnosis, daily productive cough for 3 months or more in the last 2 consecutive years, usually overweight, usually cyanotic, elevated hemoglobin. You're not really going to know that until you get them to the hospital. Peripheral edema, so they'll have swelling in their hands and feet. Bronchi or wheezing cough. We'll get into the types of cough, I think. Go back. So there's talks about types of coughs or types of breathing sounds on 531. We'll go through those in just a minute. So emphysema, pathological diagnosis, permanent enlargement and destruction of air spaces distal to the terminal bronchus. So bronchitis, where do you think that is irritating and inflaming? The bronchi, right? So it's upper airway. Whereas emphysema, we know it's attacking the alveoli, so it's lower airway. So usually happens in older people, usually caused by smoking. Severe dyspnea, they have really short breath all the time. Quiet chest sounds, X-ray, let's say hyperinflation with flattened diaphragm. So basically they're not breathing quite as well. So pink puffers. So we know these people are going to be the emphysema patients because they're the ones that look pink on the slide, right? So they usually got flesher skin. You'll see these people when they're breathing out, they're doing the pursed lips breathing. They're doing the, because they're trying to open that airway up. And so they're trying to increase the peat in their chest. So they're doing a lot of that. With the blue bloaters, these people are pretty much breathing normally. But you're going to see the discoloration, usually overweight, usually have the rhonchi and wheezing. It's kind of a little difference in what they look like. So normal airways are nice and open, right? In the chronic bronchitis, they get a lot of mucus buildup in there. So they'll be coughing. They usually have pretty productive cough. With the emphysema, you actually have a decrease in the surface area in here. So it's important that we have these little bubbles, right? Because the blood vessels are wrapped around these blood. Right. So yeah, the blood vessels wrap around each of these so that they have the most surface to flow between. Once you start widening it out like this, you actually lose surface contact with the blood vessels. And so they don't have as much surface on each of the alveoli bubbles to do the exchange of the gases.
So I'm just curious, like a smoking person,
Mhm.
like, that everything that's in that smoke basically is covering up the contact area, or whatever.
Yeah.
It's covering that up, right?
In some cases, yeah, it's covering it up, but also breaking stuff down.
Yeah.
So it starts, as it gets in there, it starts degenerating, and it starts, the words are not coming to me today. It starts drying out the surfactant that's in there and damaging the surfactant. So surfactant is what keeps the alveoli open. Think about it, it's the lubrication that keeps the alveoli open. So as long as you have that, it's good. But things like mucus buildup, smoke, anything that gets in there and destroys that, makes it so those alveoli become brittle. And we'll talk a little bit about that in tension pneumos. And the more brittle they become, the more easier they pop, right?
Yep.
So
What do you think, compared to cigarettes, what a lot of kids nowadays are vaping?
okay,
What kind of damage do you think that's doing?
tremendous. So think about what you're vaping in. So we know that when we smoke cigarettes, you're inhaling basically smoke, tar, nicotine, anything that's nasty that's in that smoke.
Yeah.
Okay, these kids are vaping, they're taking water into their lungs along with whatever they're vaping. So you think about some of that stuff's sweet, right? So do you think that's sticky or smooth? Is that lubricating or is it drying out?
It's drying up.
Right. So we are seeing people come into the ER with lung damage from vaping. And they've only been vaping for a year or two. Whereas you look at some of the cigarette smokers, my dad smoked from the time he was in the 8th grade till he was 69 when he died. Yeah, it killed him at a young age, but you know, we're seeing worse effects from vaping, I believe, from what I've seen come into the ER than what we're seeing from smoking. Yeah. Now, if you vape, that's not us saying you need to stop, you know, or I'm judging you. It's just one of those things that, you know, you have to consider the risks of what you're doing when you're doing it. So,
So like, would that would be more of a bronchitis or bronchial type?
what I'm thinking is in
Like that?
immediate time, like right now, next couple of, you know, a couple of years of doing it, this is what you're going to see because you got that inflammation from all the stuff that's in the product. Eventually, it's going to lead to this. Okay. So,
Dry out, and just kind of dry off.
yeah. What do you think about it? Basically, if you're vaping in something sweet, it's basically turning the crystal into your lungs. So eventually, it's not even going to have a chance to do that. It's just going to crystallize your lungs. And there's just no way of telling. I mean, it's too new to say, yeah, this is going to happen. This is what the long-term effects are going to have. You know, 10 years from now, 20 years from now, yeah, we'll probably be in this class going. And this one here is what it looks like when you vape. You know, we'll have that information to tell what it does to the lungs.
And you're like, never heard the term popcorn lung until vaping come around.
Yeah.
Yeah.
Basically what it's doing is crystallizing.
I think I saw something somewhere about a male and it's like mid to late 20s, so it's gonna be have to get double lung transplant.
That's possible.
So when it comes to organ transplants, like if you're an alcoholic, that lowers your priority to get like a liver. Or
It does in a way, I think. I'm not real familiar enough with it to say yes, but I would think if you're a chronic alcohol abuser and you got someone who's born with a liver disease, that the person with liver disease will go over with chronic alcohol. In a moral, ethical world, yes. But then again, they go down a list of transplants, so. And they keep that the people that know about what your history is, I don't think are the ones that are looking at the list. So, the people that are putting you on that list may know, so every time they see, okay, this kid was born with liver dysfunction, we're putting it over this person who's an alcoholic. They might do it that way. Or they might just say, this is placed on the list, if it goes up the list, just keep it
Or
on
might
the
not
list.
be a match either.
Yeah, still got to match, still got to do all that. So, yeah, I don't know, I wish I could answer that question. It's be interesting to see. I'll look that up, see what if I can find some information on it. All right, so asthma, we've talked a lot about asthma. Asthma is chronic disease that's episodic. All right, Tanner was about ready to have to teach us stuff. All right, so asthma, we've talked a little bit about it. Asthma is usually a childhood disease. You usually develop pretty early in life. As you grow, you can grow out of asthma, or you can not. So, asthma can be triggered by irritants in the air, pollen, whatever it is. It can be exercise-induced asthma. So a lot of people who work out who have asthma have their inhaler with them all the time. Could be anxiety-induced. So there's a lot of things that can bring on the asthma attack. Thing about asthma is it can be deadly. Talks a little bit about it in your book. Right. Back to that. So, asthma. So basically, the airflow is mainly restricted in one direction. So as you breathe in, you can breathe in. Problem is breathing out. So the problem is that it traps. There's another word for it, isn't it? Okay. Well, I thought there was another word for it. Could be just trap.
It says trap in the book.
Okay.
Comes trapped in the lungs.
Yeah. So it becomes trapped in the lungs and it can't get out. So what's happening during an asthma attack is your bronchi are constricting, and your bronchioles are constricted. So as you breathe in, they'll open up. So when you let out that breath, it closes down. So it doesn't let you get that breath out. And so they feel like they can't breathe. But the truth is that they're breathing in all right, they just can't get that air out. So what we do is we give them albuterol or some kind of bronchodilator that will open up those bronchi so that they can get that air out and breathe. Characteristic is wheezing sounds. You'll see these people really trying to push that air out, or they trying to get it out. They just won't be coming out. And it can be deadly. We've had a couple people here in town that have died from asthma. That does happen. So it is to be, I mean, we've kind of gotten to the point where asthma for a while there. I remember when I was growing up 70s and 80s, asthma was like, kid had asthma, they didn't even let him play sports because they were so afraid he was going to die on the field. And as you got older, 90s, 2000s, everybody was carrying inhalers around. So they were able to just fix themselves. So it became less of a concern. And now we're starting to see it take lives again. It's kind of what the normal airway looks like. Asthmatic airway they have, a lot of times if they're constantly having attacks, or the more attacks they have, they can have this inflammation kind of in there all the time and have like asthmatic damage done to their airway. But when they have an attack come on, it actually shrinks down. You'll see that constriction. And times smooth muscles around it. We give them bronchodilator that relaxes those muscles, and it opens those airways back up. So do we give oxygen to an asthmatic during asthma? If they need it, yeah. So if they're statin below, usually on an asthmatic patient, they're mid-90s to high 90s anyways, because it's so they're breathing in okay and they're getting oxygen to their lungs, but they're starting to build up CO2, right? So as they start building up that CO2, it's going to start preventing that exchange of gas to be proper. So you might see them starting to drop down in levels. It's not going to be our first treatment. Our first treatment is going to be trying to help them with their inhaler, do it right. They might be so panicked right now that they're just, breathing out and they're not getting
Not
their
good,
medication.
not too long.
Yeah. So what we want to do is coach them through it. How do you think we coach them through it? Deep breath? Yeah. So we're going to get into that when we talk about prescribed inhaler here in a minute. So. All right. So pulmonary edema, we talked a little bit about this. Accumulation of fluid in or around the alveoli of the lungs. So in your book, it talks a lot about left-sided and right-sided heart failure. Yeah. This is where fluids begin to build up into the lungs. So in left-sided, we got our heart here. Okay. Yeah, we can take go ahead and take a 5-minute break. You need the bathroom, you get something to drink. Now I need something to drink. But I can't have it because I'm on call. All right, so what are some causes of it? We started talking about heart failure. So heart failure, so when we talk about heart failure is probably the biggest one out there. Another one is drownings. You have acute pulmonary edema, or what they call flash pulmonary edema, when you have a sudden filling of the lungs with fluid. Usually it's caused by my mind just gone. Cool. Yeah. So like sudden sickness onset. So when we're talking about left-sided heart failure, we got the heart right here. So as the right side of the heart, I guess I shouldn't be standing where you have to see this. So as the right side of the heart contracts and starts not having as much contractility to it, so it's not able to pump as hard. What it's doing, left side. So where's the left side go? To everywhere, right? So if it's not pumping right, it's filling up with blood, but it's not pumping all that blood out. Where's it going to? Come back up into the aorta or into the pulmonary artery, and it's filling, or pulmonary vein, and it's filling the lungs. It's filling that space. It's going to start pushing into the interstitial space around the lungs and start putting fluid around the lungs in that area. Okay. When you think about it, the whole left side's not pushing out to the body. So it's filling up and it's backing up into the lungs. That's where we get pulmonary edema. If you have right-sided heart failure, where does it pump to? It pumps to the lungs, right? So it pumps up here to the lungs. So as it's pumping, it's not able to fill everything back up into the lungs. Where is it going to? Where's all that extra fluid going back to? It's getting backed out to the body, right? So as the blood's trying to fill that right side, when it's failing to pump all that blood out, it just keeps filling up, and it's pushing that extra fluid back out to the body. So we start seeing pedal edema. And we start seeing that edema building up in the lower extremities. And so left-sided heart failure always leads to right-sided heart failure. Because eventually what happens is that fluid not only builds up into the lungs, it starts getting pushed back into the right side of the heart. And eventually it's going to lead to right-sided heart failure. Right-sided heart failure may not necessarily lead to left-sided heart failure, but you always see that pedal edema going on.
So would that be swelling and redness in that legs?
Yep.
Would that include like a slow capillary?
Good. Yeah, if you have enough edema around it, it's going to start affecting your circulation, right? So you're going to see slower cap refills in the toes and stuff like that.
Would that be an instance where like compression socks and elevation is?
Yep. We wouldn't in EMS, but yeah, in your job, yes.
Yeah.
In a clinical setting, it's one of the most common uses I've seen of compression socks and elevation therapy is with pedal edema from heart failure.
Yeah. So right now we're talking about pulmonary edema. So left-sided heart failure leads to pulmonary edema. Okay. Congestive heart failure. So when you start getting fluid built up in the sac around the heart. I noticed in the book they said used to be called congestive heart failure, is now just heart failure. But you start getting that fluid built up around the heart. As that fluid builds up, it starts constricting on how much the heart is able to pump out. It's just like if you wrap a tight band around your chest, eventually you can't breathe in anymore. So what that does is it creates a left-sided or right-sided heart failure, and the heart's no longer able to fully pump until that fluid's off from around it.
Yeah. Exactly. I know it's
So,
around my heart, but what
right.
would be holding it?
So around the heart, you have what's called the pericardial sac. So that is a place that wraps around the heart, and it's filled with surfactant, which allows the heart to beat freely, and it's lubricated inside that sac, protecting it, and it's able to contract and relax, and that fluid allows it to do that and allows it to beat without damaging the heart, without it rubbing against the lungs or rubbing against the chest wall. So that pericardial sac protects it. Problem is you start getting leaking vessels in the heart, or that sac gets a hole in it, starts bringing in fluids from the outside. That's where you start seeing fluid build up around the heart. So that's another cause of pulmonary edema. Like I talked about earlier, we talked about drownings. We had been drowning the other day. Treatment for pulmonary edema and having fluid built up in the lungs is CPAP. It's forcing that fluid out of the lungs. Another one is Lasix or furosemide. Furosemide makes you feel it. So basically, it drains off that excess fluid by People constantly having to urinate. Yeah, flush it out kidneys too. So some of the things you might hear is crackles in the lung sounds. Crackles are kind of like, I'm gonna go over the lung sounds real quick with you. So if you go back to page 531, the special considerations when auscultation of lungs. Wheezing is a high-pitched sound that will seem almost musical in nature. Maybe it can. The sounds created by air moving through narrowed passageways of the lungs. You can be hearing a variety of diseases, commonly asthma, and sometimes chronic obstructive disease, emphysema. So the thing about wheezing, when I went through the class, I said you're going to hear it in the lower lungs. Wheezing is one of those things you can hear throughout the upper lobes or the lower in your listen. This is the high-pitched squealing noise. Crackles, as the name indicates, crackling or bubbling sound. You hear it on inspiration of the lower airway. Used to be called, it's also called rails, right? Crackles is rails. Yeah. Yeah. I didn't read very much when I was reading the journal. So yeah, so crackles up is the lower airway. Bronchi is a low pitched sound that resembles snoring or rattling. Caused by secretions in the larger airways. Maybe seeing pneumonia, bronchitis, aspirated breathing. Between crackles and bronchi, it's not always obvious and it's somewhat objective. So usually bronchi is an upper airway, so it's in your bronchioles, but usually an upper airway. What I've heard some people, and it's kind of an interesting sound, when you hear someone with pneumonia, they actually sound like someone's blowing bubbles through a milkshake. It's like a really weird, like, it's, yeah. If they have that thick mucus buildup in there, it's every time they breathe, it's that air passing through is creating that bubbly sound. Stridor is a high-pitched wheezing noise, heard on inspiration, and it is a sign of an upper airway restriction. So basically from back here up. There's some closing off the airway up here, and it's causing that stridor. Yeah, so those are the four biggest ones. Snoring. Got a wife like mine, you know what snoring sounds like. So snoring is an upper airway issue also. Usually caused by the tongue falling back onto the throat, covering the airway. All right, so pulmonary edema, fluid in and around the alveoli, small airways, causes left-sided heart failure, toxic inhalation. So we're talking about vaping. Very easily could fall into pulmonary edema. Aspiration, inhaling toxic inhalations.
Oh, thank you.
We were talking about vaping.
No, real good for you.
Aspiration, pneumonia. Aspiration, anytime you inhale something into the lungs. Drowning, and then trauma can also cause trauma to the heart, to the lungs, causes bleeding. Anything that causes any kind of fluid in the lungs could cause pulmonary edema. All right, pneumonia is an infection of one or both lungs caused by bacteria, virus, or fungi. Anybody know which of these would be the worst one to get?
Virus.
Virus, why?
Viral.
You attach everything.
Hmm?
You attach everything.
No, not necessarily. I mean, it might be just the lungs, but
Because viral infections can't be killed by antibiotics.
that's one reason. How about something else? What can we do with a virus that we can't do with bacteria?
Right.
Right. The bacteria doesn't live very long outside the body, where viruses do. So viral pneumonias are ones that you see hospitalized in negative pressure rooms, and they stay there until they're done with it. You want to make sure you're wearing a mask, wearing a gown, because it's usually contact, droplet type diseases, nasty stuff.
What about fungi? You don't know.
So fungus is usually, that's your aspiration pneumonias. Like you inhale something into your lungs and it creates fungus in there. Start
Maybe
doing
like
that.
a mold spore or something like that.
Yeah, you can get molds in there, stuff like that. So those are usually not as spreadable as bacteria. Bacteria, you can still spread it to someone else. It's just bacteria doesn't live as long outside the body as say viruses do. Yeah. Well, walking pneumonia is anytime you build a walk around with pneumonia. And so I got diagnosed with walking pneumonia like 2 years after I moved up here. And it was like they took a picture of my heart and I had a clear spot like that in my lungs. The rest of it was all fuzzy, nasty stuff. And the only reason the doctor didn't admit me at the time is he said, I would admit you, but I don't think you would actually stay. So go home, rest for a couple of days, and hopefully it clears up. And it was bacterial. So they gave me antibodies, which worked to clear it. Viral pneumonias, you just got to write them out. Hopefully things work out for you. Okay. So some signs and symptoms of pneumonia. We got headaches, loss of appetite, mood swings, low blood pressure, high heart rate, nausea, vomiting, joint pain, fatigue aches, cough, sputum. Usually you see yellow greenish sputum with this, coughing it up from the bottom of the lungs. Nasty stuff. Chest pain, and then clamminess, blueness, fever with chills. My issue was I couldn't walk more than 10 feet without stopping and resting and catching my breath. That was the only way I knew I had something going on. I didn't have any of the other symptoms. So that shortness of breath is a key. Any questions on pneumonia? Pneumonia, best way we treat it is if it's bacteria, antibiotics. Viral, they do have some antiviral medications out there, but it's usually hospitalization, fluids, and rest. And if it's bad enough, they'll use CPAP on them, help push that stuff out of their system. Oh, we ain't done yet.
We need to push it out of your system.
So like I was talking about with CPAP, it'll push the fluid out of the lungs into the interstitial space, and the body's better able to fight it out there. Makes sense?
But through the alveoli.
Yeah.
Yeah.
Yeah, you push it out through the alveoli into the blood where it goes out through the system and our blood cells take over. Okay, spontaneous pneumothorax. When a lung collapses without injury or obvious cause. So what could be some causes of spontaneous pneumothorax?
Rupture of the blood. The rupture of the blood.
Yeah, with the blood.
It's weak spot in the lung.
Right. Right, so alveoli become weakened through smoking, vaping, whatever, and all of a sudden the alveoli ruptures and starts letting air out into the lungs, into the pleural space. Eventually,
You know, what the pressure is.
oh, now your lungs is starting to leak out that air. So what's that do? That negative
You don't have
pressure.
back pressure. Yeah, you don't have the back pressure.
So you don't have back pressure, so that lung collapses. That lung still gets air every once in a while. So where's that air going? Into the pleural space, right? So what's that? What do you think that's going to start doing? Right. So it's going to start building up pressure in that negative pressure space, right? And so as that pressure builds up, you start to see movement. So this actually shows several types. So you got your spontaneous pneumo, where you have a blood happen, starts leaking air into the chest cavity, and a small pneumo might not cause any issue. They might have, they're going to have difficulty breathing because that lung is collapsed now. So that lung collapses. Now they're only breathing on one lung. They're going to have some difficulty breathing, right? Some chest pain probably with it. If left untreated, that can start building up a lot of pressure, and it can actually start pushing everything over till we have a tension pneumo. And a lot of it depends on how big a leak that is. Now, how to fix that? One of the things we don't want to do in this case is start adding pressure, a lot of pressure into that pleural space, right? Because what's going to happen? We start putting CPAPs, so say on this patient. Yeah, you're going to go from a controlled, simple pneumo, simple spontaneous pneumo, to a tension pretty quickly, right? So what you do is just get them to the hospital as quickly as you can. You know, if they're starting to show real bad signs of it, then a little bit of diesel therapy will get them in there quickly. It says in the book, sharp pleuritic chest pain, so they have real quick pain, sharp pain in the chest, shortness of breath, might be mild if it's small.
Hope you gotta relieve that pressure there and our space there and induce.
Somebody does, right? Unfortunately, it's not even too skilled, so
Well, I ain't talking about me.
He said somebody, not.
I said somebody.
Yeah,
Yeah,
somebody,
didn't you walk into the house and see him struggling breathing and call ALS?
Yeah.
so one of the clues to that, and we'll listen to, you know, if we can get the mannequin working right, we'll listen to what diminished chest, lung sounds sound like. So you hear lung sounds on this side, but you're not sure if you're hearing it on this side or you're not hearing it on this side. I might tell you they have a pneumothorax going on. They have a flaps on. And in this case, definitely CPAP is contraindicated. So you don't do CPAP on these patients. All right.
These patients here, you just.
Yeah.
You know,
You might put them on like oxygen if they need it. You know, put them on ventilators. Yeah. Good nasal cannula. Whatever you want to get them to that 94 and above 95. But you're not going to put like someone who's going to put a lot of pressure into it once.
The best thing you can do for these people is be calm and talk to them. They're going to be anxious and they're going to be freaking out and they can't breathe.
All right. Pulmonary embolism. What is that?
blood clot or a crack gets stuck in the block and hard in the lungs.
I'm sure it's right there, isn't it?
Good job.
Yeah, I forgot I put it up there. I thought that was one of the ones I did a motion on, I didn't. So, yeah, so pulmonary embolism, anytime a foreign object gets into the lungs and blocks the arteries. This can, more than likely, when this does happen, it's two reasons. We have a blood clot from a DVT that is broken loose in the legs or our lower extremities and has moved up in through the heart into the lungs. Or you have cholesterol that build up in the heart or in the arteries someplace that breaks loose and goes through the body. That's your fat and cholesterol buildup. Every once in a while, air can get in there and cause an embolism. How much it takes, I don't know. I've been told by seasoned paramedics that there is in an IV line around 5 to 10 mils of air that you flush out when you before you hook it up. If for some reason you don't do that and you flush that whole 10 mils into the body, it's probably not going to do anything for the patient. Probably. But there's always a chance it could cause a pulmonary embolism. Once it reaches the heart and into the lungs, it can cause an issue. If you think about how long one of those IV tubings is, pretty long. It's about 6 foot, 7 foot of air that's going into a patient. And so, you want to make sure if it's got little tiny bubbles in it, you're not going to kill the patient by letting those go into the body. But letting that whole line go in could cause an issue. That's why when we show you guys how to set up an IV, you're going to make sure you flush that IV on. Okay? Any questions on that? All right, pulmonary embolism. In this case, we're talking about a blood clot. You got the inferior vena cava. You got your little embolism, your little item here. It's going to go up, dumps into the heart, goes to the right atrium, up to the pulmonary artery, and gets lodged into the artery in the lungs. And basically everything that's below that clot or below that blockage is going to die off or start dying off. Last presentation, so nonsense, sharp pleuritic chest pain, worsens when breathing in and out, shortness of breath, anxiety, cough, sometimes bloody sputum, and tachycardia, tachypnea. So one of the things that's kind of similar between pulmonary embolism and pulmonary clot or edema is the bloody sputum. It'll be frothy, so real bright red, kind of bubbly. You see that, that's a concern. That's a big concern. So you want to make sure you get them to the hospital as soon as possible. Embolism sometimes can sometimes be prevented by avoiding long periods of inactivity, refraining from smoking, taking appropriate medication. So when you think about it, how many people have been on an airplane trip longer than 10 hours? Okay. It's very important that during that 10-hour flight, you're getting up and walking around. In fact, it's important on anything you do that you don't sit around and do nothing for over 5 to 10 hours. Because what can happen is start getting clots building up in your legs, stand up, you release those into your body. So get up, walk around, move around, be active. All right, epiglottitis is a bacterial infection that inflames the area around and above the epiglottis. Where's the epiglottis at? Okay. What's it do?
What did you say that?
The epiglottis, where is that?
Separate you from the sides.
It protects the airway, right? It's a little flap that goes over the airway. So when you swallow something, that thing slams shut. So food doesn't go down the wrong tube and you start choking and coughing. You don't aspirate it into your lungs and become a bacterial or a fungi pneumonia person. So, yeah, so inflames the area around it, epiglottitis. It used to be a childhood thing. Let me see. Please. It used to be mostly children that did it. They started mandating this, doing these, not mandating them, giving out these immunizations back in the 80s. It's really cut that down quite a bit. Thing with epiglottitis is what you're going to see as far as the signs and symptoms of it. They'll have a difficult time swallowing. One of the things you'll see with it is, it's on that little picture. No, that's that picture. So, with 4 Ds of epiglottitis, dysphagia. It's when a person's faces swallowing issues. They can no longer swallow comfortably. It's hurting them to swallow. They start coughing a lot. Dysphonia, abnormal hoarseness in the voice. Drooling. So think about they're having problems drooling. That swelling around the epiglottis is now forcing that drool no longer to be able to go down. So it's coming back out. Distress, difficulty breathing, not getting enough oxygen. So treatment for this, basically transport. Yep. Sometimes administering cool humidified oxygen can help with lowering that swelling. But what's your high concentration oxygen without alarming the patient? Transport as soon as possible. That's basically the treatment. Yep. These are ones you want to get to the hospital pretty quickly. Give them some steroids to help take down that swelling. All right, croup.
But what's,
No,
can I ask a
go
question back on that? So what, so the biggest indicator in an adult there is basically somebody, you walking on somebody and they're like they can't swallow.
Can't swallow, hoarse voice, they're drooling, excessive salivation. So I've seen this,
But still breathing okay.
they can be, they might have some difficulty breathing. Depends on how swollen it is. It gets to the point where it's swollen to the point where it's actually blocking the airway now. They'll have difficulty breathing, and that's why you want to get into a hospital quick. Because if that swelling does happen, usually they freak out over a lot of other things before they get to the point where they're having to a point where it's swollen enough to block breathing. But you also want to do this very carefully and very gingerly, because if you do something that agitates that and it swells more, now you're speeding up the process of it possibly blocking the airway.
What could potentially aggravate it?
For us as paramedics, actually looking at it with the light scope, thinking we need to intubate them. So if we put something down there to look at it, to intubate them, they might be to the point where their respirations are indicating that, you know, this guy's airway is closing off, which probably has higher levels, intubate this person. So we might do that, going down there might agitate, giving them something to drink or eat. So we don't want to be doing that. Putting an airway in, stuff like that, like a nasal or a oral airway. So there's a lot of things that we normally wouldn't do anyways. If we can get to them before they're getting to that point where they're struggling breathing.
And something like that, would you take consideration of not transporting them on their backs?
I would have them sitting up, yeah,
Have what?
sitting up, semi-foul, position of comfort, like that's what we talked about last week.
Yeah.
So position of comfort, where they're able to breathe best. Yeah, if they're you get them in a position of comfort. The only two positions you don't want them to be is flat on their back and on their face. So, if they're comfortable sitting up, they're comfortable in the fetal position. You know, you let them get comfortable and just monitor them. Any other questions? Is that a hard to see it look or I'm confused? About this?
Kind of see. Very nice.
I need to make it bigger next time.
Who you got? Oh, you still can't see?
Maybe it's time for
That's bad, me.
this.
Even the air ain't seen.
As Ian's already mentioned, damn, girl, you're blind.
Any other questions? I like this closed caption. I want to see if this shows up when we put it on YouTube. All right, so croup is a viral illness, inflames the larynx, trachea, and bronchi. This is one of those ones that you see a lot in children, especially younger children, usually about 6 months to, I think, 2, 3 years old. This one book up to 4. Yeah. So usually your toddler age kids, they have seal-like bark or cough. Still bark. They sound like they're barking when they're coughing. What happens is causes swelling in the trachea, narrowing of the tubes. Page 544, 6 to 4 months old. Classic presentation is a loud barking cough, hoarse voice, usually occurring just after bedtime. Associated with breathing difficulty resolves when children move to upright position, like being held by a parent. However, croup can be severe, causing inadequate breathing signs of hypoxia if it's left to go on. Another thing you'll find with croup is if you take them out to cold air, they stop coughing. Stop coughing. Cold air hits that throat, decreases the swelling, does something to it. The other thing, strictly from the warm shower, put them in a hot, don't throw them in the water of a hot shower. The steam from the shower will help them. So. And this thing can affect down into like your upper airway. It usually affects the upper airway, but can get down to lower airway. Any questions on croup? Treatment for this is usually antivirals or hospital. A lot of times, all we're going to do is give them oxygen. Keep them calm. That's why it's a hospital. Right. So bronchiolitis. Again, It's a viral infection that affects the bronchioles. This one, you'll see a lot of like cold-like symptoms. So coughing, fevers, stuff like that. This is your RSV. This is usually in younger kids, 5 and below. Cold-like symptoms, runny nose, fevers. These can progress into them needing to be hospitalized. Most of our pediatric patients that we have here in Douglas are usually RSV kids. Serum suction, the mucus out of the nose way. Everybody know what a bulb syringe looks like. And that teardrop. That's it. All right.
Now, RSV is pretty serious thing. I mean,
It can be, yeah. So when it initially presents, the reason it becomes a serious thing is when it initially presents, it appears like a cold. And so people take them to their pediatricians. Pediatrician will treat them for a cold. And then it develops into RSV.
Yeah.
So,
Well, since it can get so serious, what would be the point for if we transfer from other hospital rather than here?
if the airway is so severely compromised that they have to be intubated.
Then send them on? Or-
And it also depends on our hospitalist and how they feel that day. If our hospitalist doesn't want to take a kid, they won't take them. Usually with pediatric, you have to have a pediatric doctor accept them. And right now, how many pediatric doctors do we have at this hospital? I don't know, not a lot.
you have one?
We got maybe 1 or 2. Ingle, I think, is the only one, and she's a hospitalist, so. Excuse me, yeah. She is. But, so, as far as that goes, you're looking at mucus buildup and inflammation. So, how do you tell the difference between viral and bacterial infection? Would you like to tell me? Color of the mucus. It's clear, it's usually bacterial. It's green or yellow, it's usually viral. I say usually. So start seeing that green mucus stuff come up, then you start suspecting RSV, especially if it's an old kid like that.
Okay, so the green.
Viral.
Swine from Ghostbusters.
Mhm.
That's my preference for you, isn't it?
No, yeah, almost. Oh, that's a. For orders, I think.
All right, so cystic fibrosis,
Hey, you got Nick Martin Joey.
Oh.
Yeah, the science.
Is that by your opinion?
It's called guts and looking some respect on the name.
all right. So cystic fibrosis is a genetic disease, occurs in childhood, causes thick, sticky mucus to accumulate in the lungs and the digestive tract. Used to be, if a child was diagnosed with this, they didn't live to adulthood. With the new treatments and stuff that they got out there right now, living past 18 is actually fairly common. This is a fairly serious disease. Kids that have this, their parents know how to treat it. They might still be calling us to help them because of whatever is going on is beyond what they can do at their house. So if you get there, rely on the parents. If the parents tell you, hey, this is how we treat it in the past, listen to them, treat it the way the parents tell you to treat it. And that goes with pretty much any of these diseases that are serious and long acting. And usually the parents know about it. Listen to the parents. They're the best information you can get.
So
So,
what's common treatment for cystic fibrosis, like nebulizer treatment?
no, usually, let me see, I have to look at this one.
Yeah, it doesn't say.
Yeah.
Basically,
Yeah.
what you said.
Yeah, for us, it's just listening to parents. If they say DONAB helps them, then assist them in doing a DONAB treatment. If they've said they've already tried 3 DONABs, 3 albuterol treatments, they've suctioned the airway and they've done everything, load them up, put them in the back of your truck and go to the hospital. Oxygen if you got, or if they need it. Usually on these, it's going to be a tough, if you're getting called to a house, it's going to be a pretty serious call. I get ALS on the way. That way, if they need to do something more like intubation or something like that, they can. Anything else on that one? Okay. Some common symptoms, salty tasting, can't read that, skin. Oh, I'm not gonna be looking at their skin to find out. Poor condition, or poor growth, or severe weight loss. Mucus in the digestive tract. You'll see bulky, kind of greasy looking stools in these kids. Lung infections, these kids get infections in their lungs very easily because that mucus that's down their lungs traps bacteria really well. Start seeing a lot of that bacterial and fungal pneumonia in these patients. Chronic respiratory problems. So basically with these kids, with the parents get them to the hospital. More than likely, if the parents could go to the hospital on their own, they would take them. All right, viral respiratory infections. Catch all. If it's a virus and it hasn't been labeled already, this is the category it falls into. So this is your influenzas, your SARS, your H1N1s, your COVID-19s, any kind of viral infection that affects the lungs falls into this category. There are a few antivirals out there right now. The best way of preventing them or recovering more quickly when you get it is to get the vaccination. There are some more tried and true vaccines for COVID-19, but the stuff we're seeing right now is like cold-like symptoms. Most of the people that are testing positive for COVID-19 don't even know they have it. So, SARS, H1N1, so your bird flus, your swine flus, stuff like that. We are, it's
H1N1 was like.
just swine flu.
12 or 15 years ago.
Yeah, that was just swine flu. That was back in 2009. Bird flu came out a couple years before that. About every 4 years we see a virus come up. Yeah. So, and there are millions, there are hundreds of thousands, if not millions, of influenzas out there. So there's no way you can get vaccinated for all of them. That's why the flu shot that we get every year has top 3 in it. Usually the 2 that were big last year and 1 that they suspect is going to be big this year. And it isn't necessarily going to prevent you from getting the virus, but it is going to help you fight it off. So, any questions on best treatment for this, what we're going to do is if they're having breathing problems, we're going to give them oxygen. Go to the ER basically. What we're gonna do to protect ourselves is if we know we're possibly walking in on an influenza patient, we're gonna put a mask on. Use droplet protections.
Wouldn't tuberculosis also be covered under,
It's its own little, you're right, it should be, but it is its own little category under infectious disease, and we'll get into that. Yeah. We're talking about respiratory emergencies. TB is a chronic illness. I mean, I guess cystic fibrosis is also a chronic illness, but it's a little bit different because most of those people can manage on their own fairly well. Whereas with TB, once you get it, as you progress into it and it becomes chronic, you're always going to have that issue. That would be the only reason I could think it's not under any of these. And I do believe we cover it later on. So we're going to talk about prescribed inhalers. So if you look on page 548, we have that. All right, so how many people have seen or used or have had one? Just about everybody. So the important thing to do is knowing how to properly use it, right? So
This one?
all right, so there's a lot of different versions out there. This is one. So and this is one that you guys are probably more used to seeing. All right, so on page 548. No. On 548, we got little instruction steps on how to do it. And this is where we talk about those rights. So if you look on page 558 and then number 4, it says ensure the 5 rights. Right patient, right time, right medication, right dose, right route. And then when you go to do your documentation on it, you're going to make sure you document it right.
Did you say there were 6 rights?
Yeah, the 6th is documentation.
Oh, okay.
So,
I'm sorry.
but when you're giving this to the patient, you want to make sure, one, the patient is who the medication belongs to. You don't want to be giving them someone else's medication. The right timing that you're giving it to, at the right time, not, okay, I was having difficulty breathing an hour ago, now I'm not. Okay, you got an inhaler, let's give you an inhaler. So, if they don't need it, don't give it to them. The right medication. So, what are some cases where we could possibly give a wrong medication? Anybody can think of one? Yeah, there's several people in the house that have medications.
Sports teams.
Yeah, sports teams. You want to make sure you're giving Tanner's medication, not Ian's. Okay. Why would that matter? And let's not think about inhalers, because Inhalers are giving you one dose of medication. It gives you the same every time you press it, so it really doesn't matter. But think of if like some medication, he might be on a higher dose of medication than he is, even though it might be the same medication.
Yeah, it could be, good, yeah.
Yeah, so it could be a different dose. Yeah, and so you want to make sure it's the right dose and the right route.
Another thing is if they know they have a prescribed bureau, but it's not on them. Have they always given them doing that? That could be a wrong medication, even though it's the same medication.
All right, so when you do this, so administration, we're going to read through this administration real quick on it. So obtain the order from medical direction, either online or offline. So what's an offline medical order?
Standing order.
Standing orders, right? So there's certain drugs, and I'd have to look. I meant to do that today, but we got kind of busy to see whether or not these are, because what you can do with these is you can assist the patient with their medications. You can't like grab our albeit, we don't carry albeit, well, we don't carry these on the trucks, but you can't like grab someone else's medication, just give it to them. So you can assist them with it. So how you're going to assist it with them is you're going to talk them through these steps. And one is get the, okay, so is it an online order that you have to get? You have to call in and get permission, or is it something that can be a standing order? Now, has anybody ever looked at these? Okay. Is there any labeling on them other than what's currently on? Right, where's the labeling at that identifies the person, the expiration date and all the expiration? Right, it's on the box, right? I believe this one has a lot number on it. And it's got the dosage on it. So this one here is placebo inhaler.
How many doses?
Hmm?
Does it say how many doses?
Just
This one
says,
says it has a total of 400 doses.
400 doses.
yeah, this one does not. I believe that's a real thing, though,
And this one's placebo.
isn't it?
They used to have
This
things
is
that like
400
counted
meter
on
inhalation.
Yeah. Yeah, the ones I have at home have a counter on it. And now it depends on it, because like mine counts down, some of them count up. So you just need to be aware of that. So you're going to make sure it's not expired. You're gonna make sure it's the right patient, right time, right medication, right dose, right route, and that the patient is alert enough to use the inhaler. So what's that mean? If they're unconscious, can you help them with it? No. If they're not able to answer simple questions, are you gonna help them with it? No. They have to be alert enough to follow your directions. So you're gonna check whether the patient has already taken it and how many doses. So if they've already taken it 5 times, I'm probably not gonna help them with the 6th. Okay, I'm gonna call ALS, get them coming, or I'm just gonna take them to the hospital the way they are. Ensure the inhalers are room temperature or warmer. Some of these, if it's like temperatures we have, it's a fluid inside it. Okay. So when you press it, it aerosols. You're negative 20 degrees and it's been out cold for that long. You think that's still fluid? Or is it possibly starting to freeze up? Yeah, so you want to make sure it's room temperature or warmer. Shake it vigorously several times. And then prime if necessary. So prime it just means squirt it once. Now the problem with squirting it once is you just lowered their dosage in there. But if it's like this, if it's one of these, you usually don't have to prime them. They're ready to go. Okay, it usually squirts out pretty easy. Especially once you shake it. You're gonna have the patient exhale deeply. Instruct the patient to put the mouthpiece of the inhaler in their mouth, past their teeth, and above their tongue. Have the patient depress the handheld inhaler as they begin to inhale slowly and deeply. Instruct the patient to hold their breath for 5 to 10 seconds or as long as possible so the medication can be absorbed. And that's probably the most important part of this, is instructing them to hold it as long as they can. Okay. If you tell them 5 to 10 seconds, they're probably going to start counting and they're not going to be quiet about it. Instead of counting in their head, they're going to go 1, 2. While they're doing every time they do that, they're breathing that medication out. Resume supplemental oxygen if necessary. Wait 15 to 30 seconds and repeat the second dose if necessary.
So asthma is the bronchi, right?
Yes.
So if you inhale and you hold for 5 to 10 seconds, you've got your inhaler medicine into your lungs, right?
Yeah.
And so is that being effective, or is it just the medicine that is across the bronchi?
Okay.
That is being effective.
Right. So when you inhale it,
that in your entire airway now.
right. So think about your airway. So when we were talking about dead space, remember the other day with Greg, we're talking about dead space. Where's that dead space at? It's in the bronchi, right? Bronchioles and bronchi. So it's where it needs to be. Now you're going to have some of it up in your upper airway. You're going to have some of it in your lower airway, but most of it's going to be sitting right there where it needs to be. And then it's going to start activating. And then document as needed. And again, if they haven't taken it yet, and you're assisting them with it on their first time, yeah, you might need to do it a second time. Just, don't sit there and every 30 seconds be giving them a hit off their inhaler. Give it to them once, wait, see if it works. Give it to them again, wait and see if it works. If it doesn't work that time, I'd be on the phone with medical direction and saying, hey, it's not working. And he'll tell you to probably just give them oxygen and come in.
Correctly, they can assist with the first dose without medical direction. I think maybe you can assist with medical direction.
Yeah, we'll have to look that up, make sure. But yeah, I was thinking it can be a standing order for assisting the first dose.
If you get in that position and they want to just measure oxygen, it's going to go through the.
What was that?
If you say it's not working and they say just give them oxygen to come in.
Yeah.
Is that what you want to give them oxygen through just to those like you would? What do you call that?
Whatever they need. So
Does it have to be, would it be some type of breathing?
no, it's just a matter of how much do they need. If they're sitting in the low 90s, and they're having difficulty breathing, you can probably get away with the nasal cannula. If they're down in the 80s, probably think about a simple mask or a non-rebreather. All right, so some of them have a spacer on them. So the spacers are usually used with kids or people that have a hard time doing the inhaling. And basically it's the same thing, but this time you're going to spray it into the spacer. It's going to go into the spacer, then you're going to have them take a deep breath. Because they don't either, for people that have this, either they don't like the spray going straight into their throat type thing, you're blasting something into their airway. So they'll have a spacer, you put it into the spacer, they inhale, they get the medication that way. Okay. But same thing, they're going to hold their breath as long as they can. Okay. Some side effects to look for: tremors, increased pulse, and nervousness.
So, for like little kids, Max had an inhaler and he was like Yeah, than just over a year old. How are you supposed to do that? Because I don't think they'll listen if you don't invite them.
A lot of times, that's why they use the spacer.
Okay.
They'll put that spacer in their mouth, they'll push it, and that, yeah, just hold it there, and
Okay.
they're breathing that stuff in.
If you didn't have like. Yeah.
So, all right, we're almost done here. Now we can do some more fun stuff. Small volume nebulizer. Well, the most common drugs that we see in this are albuterol, ipratropium bromide, and Duoneb. So they're all, and guess what Duoneb is? It's albuterol and ipratropium bromide. So the two can be separate, used separately, but they can be used together. Another one you'll see at the paramedic level is racemic epi, and it's used to treat croup. It helps take down the swelling in more severe cases of croup in the airway. It comes in little things that look like this. We call them bullets. Pop the top off. Squirt this stuff. Into this little cup thing. Attach the top, either attached to a mask or a peace pipe. Peace pipe is a long tube thing that they put in their mouth and inhale on. It's not called peace pipe. Don't know what it's called, mouthpiece with a tube on the end. And they inhale this into their lungs. You attach it to oxygen, what it does is it atomizes the medication and allows them to breathe it in. And it works actually fairly well. And what are we doing tomorrow? Test and practicals. So tomorrow, this is looking like we're getting into 9 o'clock now. So if we have some time, we'll do a little bit of lung sounds, but I'll come up here tomorrow and get Sim Man working for tomorrow night's practicals. Yeah, so if you look on page 551, it's got a picture of what this looks like. And if you look at that long tube thing, that's what I was talking about, the peace pipe, that's what I call it. Even most of the COPDers or people who use this say I do a lot better with the peace pipe, or no, I do a lot better with the mask. So either way, if they can't hold the oral tubing that they need to breathe it in, then just put them on the mask and it works really well. Listen to their lung sounds. You will actually, like we had a patient today that had crackles in her lungs. We put her on the albuterol. Little bastard. Show it. All right. He gave her an albuterol treatment, or no, a Duoneb treatment. Cleared her up. We got in. The doctor said I couldn't hear any crackles, so I sent her home. So you guys cured her before we got there. She had other issues, but we were able to at least get the breathing problem cleared up before we got into the ER. All right. This is a, can you do these? Can you do nebulizers? So this is an A and above skill. I believe in some places this is becoming a basic skill, but at least for Wyoming, it's an A skill. Yeah. All right. Any questions over those? We're going to get a lot of practice on some of these later on. All right. Now the fun part. Check on learning. See if you guys learned anything. All right, what is the normal range for respirations for an adult? Well, 20. Low to 20. 3 signs of inadequate breathing.
Shallow, shallow.
Hello.
Cyanosis, noises, and
Unequal.
tripod posture.
Huh?
Unequal.
Unequal breathing? Yeah.
Is blue not a good enough answer for you, Ian?
It's not a good enough answer for the national registry test.
All right,
Is the word.
Cyanotic or cyanosis.
Yeah.
okay, so any of these things, changes in color, irregular respirations, silent chest, agonal respirations. What are 3 sides of the pediatric chart? Appearance, skin color, what was that? Yeah, work of breathing. Right. And what are the 3 common drugs used in albuterol?
Hypotropium?
Isotropium bromide and.
Yeah,
Huh?
it's just listed, but do a.
Yeah. So doing that is albuterol and isotropium bromide combined. So, good job.
One question you're gonna ask.
When you administer.
Right, so you.
Right.
That's right.
Do you have any allergies to medications?
You're right.
So one of the things with that isotropium bromide is it is made with a nut. With nut oil. So what would happen with nut allergy?
I'd have the opposite effect.
Yeah. That would really be a
But you
sucky
give
day for them.
it all too, and that's what's in the morning, should we call?
We had a respiratory problem, that's a respiratory emergency.
Yep.
They went from respiratory what to respiratory what?
Distress to arrest.
Well, distress not failure.
All right, so any questions over what we went over tonight?
What's the biggest difference between the CPAP you guys have on the bus and like one that they get someone for CPAP? Yeah, 'cause
Okay,
that's the,
so basically there's no real difference as far as the way it works. The way with our CPAP, we can plug this right into an oxygen tank and run it off the oxygen tank. Whereas our old CPAP unit was a machine. And what that machine, with this one, I can go into a house, hook the person up to CPAP, put them on oxygen, take them out of the house, put them in the ambulance, and switch them over to my oxygen in the ambulance. With our old CPAP machine, if I hooked a full bottle up to the CPAP machine in an upstairs bedroom, by the time I got down to the first floor, I had to change the bottle. You just use more oxygen. Now, a CPAP device for sleep apnea is basically drawn off from there. It's kind of like a concentrator that they use in, most of the people use in their homes. It's pulling in atmospheric air and just keeping that airway open. That makes sense?
Yeah.
So that's the only difference between them. With ours on this one here, like I said, we run it off about 8 to 12 liters per minute. And that seems to be pretty good for keeping the airway open. The ones we initially got, you had to have a 25 PSI regulator on your oxygen tank in order for it to work. And those things went through a lot of oxygen. The CPAP machine, you had to have it cranked all the way open in order for it to work. In fact, a lot of times on the side of our oxygen tanks, you have these little screw-on device areas here. So when I hook my vent up, this is where we screw it on, and that's a direct airway. just as an open airway. It's feeding everything in this tank through this hole. There's no regulating. So when we have this hooked up to our vent, we go through a lot of oxygen, depending on how we have our vent settings. With the CPAP, it's continuously blowing that out. So it's gonna drain this tank real fast. Does that make sense? Yeah. So that's why we went to this style of CPAP. And I've actually had better luck with these. With our old one, patients would get real claustrophobic and anxious with how tight it had to be. These still have to be really tight, but you can usually work with your patients. I haven't had as many panic attacks with this style as I did with our old style. I don't know about you guys, if you've had any issues with them. All right. Let's do it Monday. Yeah, so we don't have to tear this down the fire yet. So I'm gonna leave this up and work on this tomorrow. Be done working out or something. See if we can get him up and running. If you guys want to come up and take a look at him, we will. I'll play with him a little bit here, see if we can get him breathing, talking. Other than that, you guys got anything for him? Still a little bit early, but yeah, do you guys want to go over your tests?
I didn't get introduced.
So they want to go over your tests, so sit back down.
It's up to you guys, do you wanna go over it?
Case,
You missed out on our whole conversation.
Yeah.
I did.
We're actually